All right, since we've got a lot to go through and an hour to do it, I'm going to go ahead and get started. So I want to welcome everybody that's here, and I know everybody's busy and we've got a lot to cover, so we'll jump right into it here in a minute. I'm excited to have everybody join us tonight for my guest presenter, Dr. Deborah Manjoney, here to talk about how to treat leg veins in a Medspa setting. I'm going to turn it over to Dr. Manjoney in a couple of minutes. But before I do that, I want to share just a little bit about myself and my background for those that don't know me. My name is Don Berryhill. I'm also known as the laser coach, and I've worked in the medical laser industry for about 25 years in sales and marketing and training for various manufacturers and companies. And so I understand this industry really well from the inside out. I started my laser coach consulting business a few years ago to use my experience in the industry to be an independent resource for helping those looking to purchase lasers and energy-based devices become better educated consumers, basically. And as anybody who's purchased a laser or one of these devices before knows, this industry can be very confusing and very frustrating, because the various claims that reps are sometimes a little misleading. No company ever has the second best laser. Big companies are often known for their high pressure sales tactics and so on. And I've had a lot of people tell me over the years, I wish there was somebody in the industry that I could talk to about this stuff. And so I try to be that guy. One of the services that I provide, for example, is helping customers sometimes be better negotiators when dealing with these large companies or high pressure sales reps. And I've helped people save sometimes tens of thousands of dollars when buying some of these devices. So basically, I know how to play the negotiating game like they do. Sometimes I find alternative service options for customers. Sometimes the manufacturers are slow, expensive, and there's other options out there for certain devices. I can also provide advanced training options from either myself or other trainers that I work with that might specialize in certain technologies. I've got great contacts for marketing assistants to help people be financially successful with their device once they buy it, and also help with finance options for anyone that needs it. And lastly, I've got excellent partnerships for buying and selling used and new lasers and devices. And my role in that is to help you understand your options, narrow down your choices based on what your needs are and your budget is, and then help you find the best deals. And I'll be there every step of the way to make sure that you're taken care of during the sale and after the sale. And also, many of my customers get a special laser coach discount when I'm involved in these. Okay, so please think of me as your first call for anything laser, and I'll try to help you out. If I can't, I'll find somebody who can. You can learn more at lasercoach.com is my website, which I forgot to put on this slide right here. So anyway, I'm going to turn it over to Dr. Manjoney and have her give you start the presentation and have her tell you about her background. And then she's going to go through the presentation, and I encourage you to put questions in the chat, and she will answer those. And so we'll turn it over to Dr. Manjoney.
Well, thanks, Don. Thanks for inviting me this evening to talk. And just to put in a word about my experience with Don, during COVID, he was able to do some virtual training of some staff so we could have some ongoing training while we were closed for that period of time. And just remember, this is the time of year when laser reps are going to be knocking down your door this last quarter because they want to make their quotas. So it's a great idea to talk to somebody who knows how to negotiate.
Yes.
So just to say that, Don, we've always been happy with your services. So I am Deborah Manjoney. I am a retired cardiothoracic surgeon. I practiced cardiovascular and thoracic surgery for 17 years. 2 of them overlapping my opening of a vein center in Medspa, and I've been doing that now for about 20 years. So we have been a very busy vein center. My background certainly led me toward doing some treatments for veins. I thought it would be a good segue when I knew I wanted to get into a business opportunity where I could start a medical spa as well. And just to let you know a little bit about my background, I went to medical school at the University of Vermont, did my general surgery training there, and then my cardiothoracic training at the University of Chicago. I have been chief of thoracic surgery in Brooklyn, New York at Kings County Hospital, worked at Downstate Medical Center, then a small practice in Erie, Pennsylvania, not a very small practice, smaller hospital, but a very busy practice. And then I was in Milwaukee, and I have been here for the last 30 years altogether. So it's been a journey for me to do different things. One nice thing about medicine is it does give you an opportunity to venture into different fields within medicine and try to tie your specialty into it. So part of my specialty was being able to do vascular work. Another part was being a woman and knowing what other women might be looking for as I started to look for things too in a medical spa setting. So tonight I'm going to talk about the pros and cons of treating leg veins in a medical spa, and to try to help you know what you can probably safely do, when to refer on, and just give you a little bit of background about venous disease in general. So I'm going to just share my screen with you now. And we're going to talk about the treatment of leg veins with lasers and other modalities, pros and cons. And basically what this means is spider veins, when to use laser treatment and when is it not enough. Okay, so we're going to go through several things tonight. First of all, the incidence of venous disease, talk about what the veins in the legs are, how veins function, manifestations of superficial venous disease and symptoms, how we check people out, the treatment options that are available, and what kind of treatments there are, then some before and after photos. And you can ask questions throughout this presentation. So don't just hold them on till the end. If something comes up and you would like to know a little bit more, just go ahead and write in your question in the chat, and I will get to that because Don will alert me. So venous disease is actually a very important disease, and it affects more Americans certainly than arterial disease. So peripheral venous disease affects 40 million Americans. That can range from spider veins to very serious types of problems. So to just review the veins in the legs, the deep veins are the important denting veins, and they're located underneath the muscles. Superficial veins are between the muscle and the skin, and they just collect blood before they dump it into the deep veins, and they drain the skin and the soft tissue. The superficial veins have two major veins, the great saphenous vein that goes up the inside of your leg from the ankle to the groin before it enters into a deep system in the pelvis or at the inguinal area. The small saphenous vein, which goes from the heel to the crease of the knee on the back of your leg, and then it enters into the popliteal vein, which is a deep vein underneath the muscle, so it can drain that way. And then there are accessory veins of the saphenous system, especially one is an anterior vein, one is more posterior, which just means it's kind of more toward the medial aspect around the back. And these can be very significant veins that can cause significant problems if they're not working properly. Then there are tributaries of these veins, reticular veins, and spider veins, and we'll go through what those all are. Then perforator veins are communicating veins between the deep and superficial veins. When I explain that to patients, what I say is that the veins in the leg are like two stringers on a ladder, and the perforators connect like the rungs of the ladder do. So even though it's really more like an A, that you start off down at the ankle and the veins come together at the top to enter into the femoral veins, the common femoral vein, which is a deep vein that goes into the pelvis, basically is how all the veins connect. So this is just a diagram of the veins in the leg. The deep vein, femoral vein is called the femoral profunda, but there are perforating veins there that you can see. Femoral vein is another deep vein of the thigh. Popliteal vein is where the femoral vein becomes the popliteal vein, it joins, and then these are all the deep veins in the purple. And then the superficial veins are this darker purple color, I guess more periwinkle. And then you have which is the great saphenous vein here. And then it goes all the way up on the inside, and the small saphenous vein you can see in the back. Now, how do the veins in the leg empty? So again, you can recall the veins are the emptying vessels of the leg. Arteries carry the oxygenated blood in, and the veins return that blood after the oxygen has been removed and it's functioned in the leg back up to the heart to be recirculated through the lungs, go back to the heart and go down into the arteries. So the direction of the venous flow is what causes the problem, because we are upright creatures and gravity works against us. So the veins have little leaflets that form one-way valves every several inches up the vein. And these valves close and open in response to the heartbeat and also in response to how your calf muscle is contracting. So the calf muscle you can think about as another heart. It's a heart in your leg that's pumping the blood up. And what happens is when you contract your calf muscle, you're opening up a valve to let the blood up, and the valve below it closes. So if these are muscle fibers, the blood is actually pumped up in that way. Now, these are two separate non-equal systems. The deep system is much larger and it drains 90% of the blood in the leg. Superficial veins have a much more minor role in draining the leg, and they're really more collecting. However, if they are not working, then they can dilate and the blood pools in the legs, and they are the major cause of venous symptoms in the leg. The deep veins, if they're damaged, there's often nothing that can be done to improve them. DVT, deep venous thrombosis, is the source of the majority of unexpected hospital deaths, because as a clot forms in those veins, there are no valves within the pelvis and chest, and so there's nothing to stop a clot from going to the heart and lungs. And just so you can see that sometimes superficial veins aren't visible on the surface. You know, we have a layer of fat between the muscle and the skin, and you may have some veins that are closer to the surface, but the saphenous vein, which is the major trunk vein of superficial veins, is between two layers of fascia. So it's almost like it's got its little girdle around it, the whole length. A sleeve that surrounds this vein frequently keeps it from elongating or trying to hold more blood, but it can dilate. Whereas the veins that are closer to the surface of the skin don't have that fascia around them, don't have a sleeve around them. And so those veins are what become varicose. If you think about a line at Disney World or a line at the airport, the way they can accommodate more people is to have horizontal back and forth zigzagging lines rather than just a straight line. And so these veins, which ordinarily are straight, when they start to have more and more blood that's pooling in them, they elongate and stretch out and zigzag, and that's why you see those ropey veins on the surface of patients. Those are varicose veins that are superficial veins, but not contained in any sheath or sleeve. So there are several signs of venous disease that you can see here. The venous disease or veins may be not even visible and still be a problem. The great saphenous vein and the small saphenous vein being in those sleeves, you don't see them on the surface. There's a layer of fat between the skin and the vein. And so you may not know that there's vein disease just by looking at the leg. Then you can have spider veins, or you can have varicose veins. Swelling in the ankles can just be a sign that you see. Hyperpigmentation, and this is frequently just a deposition of hemosiderin that can cause discoloration of the skin, but it can also lead to thickened leathery skin of the ankle and the calf. And then ulceration, which can occur. And ulceration occurs because with a minor injury or with no injury at all, the skin is not going to heal properly because of the congestion caused by these overfilled veins. So symptoms that can occur, and symptoms that you have to ask people about when you're trying to determine if they have significant medical venous disease, include heaviness in the legs, swelling, aching or pain, especially at the end of the day, fatigue in their legs, restlessness. Restless leg syndrome, believe it or not, probably 40% of people with restless legs have a venous problem that their primary care doctor doesn't know about. So many people who have a restless leg syndrome should be evaluated for their venous system to determine if something can be done to make that better. Painful leg cramps, that especially those that awaken people at night from sleep, it's not just deprivation of potassium. Often it's from venous disease and those metabolites that can leak and sit in your leg because they're not draining properly, going back up to the heart and lung. And then itching is a very common symptom of congestion of these veins in the legs. So when we do an evaluation in our vein center, we do a very thorough history and we check the symptoms. We get a work history because anybody who stands for long periods of time is more prone to aggravate venous problems. So if somebody is a nurse or a hairstylist or a waitress or a doctor, that can really become a lifestyle issue that makes venous problem worse. Number of pregnancies. We take care of a lot of Amish patients here, and they have 12, 15, 18 pregnancies. And so their legs can be very, very diseased and have a lot of varicose veins. And the family history is very important. I would say probably 90% of the patients we see with varicose vein issues have a family history of varicose veins. Then we do a thorough physical examination. We do a classification of the type of venous problem it is. And we also develop a clinical severity score, which is a standardized scoring method that we can use them when they come in every visit, even after they've had their treatment, to make sure that they're doing well. And then the most important part of doing an evaluation for venous disease really is an ultrasound study. And the ultrasound should be done with the patient standing up, so we see the effects of gravity on the leg. And we look both at the deep and superficial veins to determine which system may be causing the problem. Then I do the interpretation, and we recommend a course of action based on the symptoms and what our findings are on ultrasound. So the ultrasound can identify any abnormalities in the walls of the vein that might indicate somebody in the past had a clot that has now reopened. So it can also tell us if there's any acute or chronic inflammation in the veins. It lets us see if there's valvular incompetence, meaning those valves that I showed you earlier are stuck open. And that's when blood can reflux back down the leg because there's no check valve in place. And we also can look at the anatomic variability so that we're guided to the proper treatments for these patients. And the good news is that today, the methods of treating vein problems that are significant medical vein issues can all be done in a minimally invasive fashion. We do nothing with more than an 18-gauge needle as far as the size of puncture or wound that is present on the leg. So we frequently will thread a little tiny laser fiber up inside the saphenous vein or the small saphenous vein if they're not working properly. And then after giving local anesthesia only, we can activate our laser, withdraw it, and we close the vein from the top down. We also use something called Verathena, which is an FDA-approved foam that's made from a special detergent that foams up. And that can be used to also close veins with a single injection. Phlebectomy, we tend to use a lot of that, maybe because I'm a surgeon, but we can remove the veins through little tiny needle punctures in segments. So again, using just local anesthesia, we can get the procedure done at one time instead of multiple trips back to a physician's office. Sclerotherapy, which we will also talk about a little more, is injecting a product, a solution into the veins. Sometimes we'll foam it to make a dense shaving cream density foam. But this sclerotherapy is a medication that we inject to get the vein to go into spasm immediately. And it's an irritant that's going to help destroy the inner wall of the vein so that eventually the wall of the vein goes away and the vein gets absorbed by the body. So you have to give it time. And that's one thing you have to know about sclerotherapy is that you shouldn't be doing it every day or every 3 or 4 days in the same area. You need to give the body a chance to resorb that vessel. So what are reticular and spider veins? And these are the veins that can be treated. Some of them can be treated in a medical spa setting. So these are the blue and red surface veins that are 0.1 to 3 millimeters, very tiny little veins. Symptoms usually just related to spider veins can be some itching. They can get some throbbing at night, especially, or after they've been standing a long time. And they can have a restless crawling sensation on the outer part of their legs. Most frequently, they occur in the lower extremities and on the face. And some of them can certainly be treated. Causes of these veins, varicose veins, hormonal influences, collagen vascular disease, trauma, bruises can lead to these veins forming, and some of it's congenital and genetic in nature. So there are several different etiologies for and causes of spider veins and these larger reticular veins under the skin. So when should you not treat spider veins in your setting in a medical spa? When there are signs of additional venous disease, do not treat the spider veins. You have to have these other veins evaluated first, or have the leg evaluated first. If the patient has symptoms of venous disease, as I mentioned earlier, the aching, swelling, if they have leg cramps at night, those things need to be identified and need to be referred to somebody who knows how to take care of these, because those veins have to be treated first in order to have successful treatment of spider veins. Spider veins on the inner aspect of the leg, the medial aspect, around the knee or on the inner thigh, frequently that indicates that there's a little branch coming from a saphenous, a great saphenous vein that may not be working properly. So that's an area that I hesitate to treat without doing more of an evaluation. But again, that varies depending on what the patient's symptoms are. And we can do things here in our office using ultrasound to see if there's any little branch connection. If a patient expects this treatment to be a one and done, don't even start because spider vein treatment is a process. And you have to make that clear to the patient that it may involve injection therapy as well as treatment with a laser. And it's going to be treatment that they're going to be seeing you several times, 2 to 3 times on average, if you're using sclerotherapy, and more often if you're only using a laser to get this taken care of. And if patients expect insurance to cover treatment for spider veins, again, don't take them on because that's illegal. No insurance company allows treatment of spider veins unless they've hemorrhaged. So again, the signs of varicose vein disease or significant venous disease on the left here, you can see if somebody has varicose veins, don't treat their spider veins. They have darkened, hard or leathery skin, or if they have swelling in their legs. Those are the signs of venous disease that should alert you that this person should be referred to a vein specialist or a vascular surgeon. Symptoms of venous insufficiency, however, we discussed the pain and heaviness in the leg, restless leg symptoms, leg cramps, or itchy skin. So if any of the patients that you see have those conditions or those concerns, your best option is to refer those patients to a vein specialist. Now, many times you'll have a vein specialist who might be an interventional radiologist or an internist who's decided to do some vein procedures, and they're not going to treat spider veins at the end. And so then you can tell the patient if the spider veins aren't going to be taken care of after they have treatment from a vein specialist, then you can go ahead and treat them once all those other treatments are done, so that then you can treat spider veins and have a much better chance of getting rid of them. So what spider veins can you treat on a primary level without having to wait for them to have any kind of venous evaluation? And these are kind of, yes, you can, but just be aware that you might still have to refer them. If they have spider veins on the outside of the thigh or in the back of the thigh, and they're asymptomatic, frequently you can take care of those vessels and those spider veins because they are not connected to a trunk vein that's having a problem. If there are little scattered broken segments of isolated spider veins, like little pieces, little worm-like structures, I don't want to say worm because that makes you think of varicose veins, little wire type of things or little threads on the surface of the skin or appear almost on the surface of the skin. And they're little pieces and not a whole arborizing tree or bush of veins. Those can probably be treated with a laser with good success. If you have spider veins at the crease of the knee and back, that's frequently an area that you can treat well without having to have a venous evaluation if the patient is asymptomatic or only has symptoms when they're sitting in the car driving or something and it's only the back of the knee. That is the one area that we see that patients can have aching and discomfort that can be taken care of and frequently don't have any other venous disease when we do an evaluation with an ultrasound. And then again, residual spider veins after they've already had a venous ablation of the larger veins that are causing the problem. The one caveat I want to leave you with, though, is if spider veins don't show any improvement, 6 weeks after a second treatment, refer the patient to a vein specialist because there may be a bigger problem that you don't see on the surface. But the other thing you need to remember is that the treatment gold standard still for spider veins and little tiny reticular veins is sclerotherapy. So lasers are an adjunct, but sclerotherapy truly is still considered the gold standard. With sclerotherapy, we're using FDA-approved solutions for the most part that are detergents that we can foam if we need to close a little larger vein, or we use as a liquid to get into little spider veins. We use either a 30 gauge or a 27 gauge needle. So it takes some skill and some getting used to, but it's actually a very easy procedure to learn and to feel comfortable with once you start doing it. And you can inject these little spider veins. The sclerotherapy agents we use, the two top ones are detergents, the sotradecol and a sclera, polydocanol and sodium tetradecyl sulfate. And these can be purchased only from the companies that make these brand names of solution. That's the only way you can do it legally. And they make just certain concentrations, which you might need to dilute in your office setting. Now, glycerin, 72% glycerin is a compounded agent. And actually, you can kind of think of this as sclerotherapy 101, even though it's not FDA approved for injecting into little tiny spider veins, it's actually a very safe treatment to do. And the reason I say that is because it's a little bit thick. So it's more viscous than the other two, which are much more liquid. And especially when people want to treat around the ankle or on the lower part of the calf, it's nice because you don't have to worry about the glycerin that you're injecting under very low pressure on the syringe, getting into any of the arterial connections in the foot. You do have to remember that there are end capillaries that go from venules to arterioles in the foot, and you have to be very careful at all about injecting any kind of spider veins in the foot because of those connections. The last thing you want to do is cause an arterial blockage or an artery to go into spasm and close off, because patients can lose digits. They can even lose a lower extremity from that being done. The other thing we can do in our office is a micro-PHLEBECTOmy. So if a reticular vein is pretty prominent, even though it's not maybe bulging greatly out of the skin, we can use a little local anesthesia. And after we've done some sclerotherapy, we just make a little needle puncture. We hook that vessel and divide it and try to take out just a little segment on either side, and it comes out very easily. And what that does is it divides the vein so that there's not blood flow through that area, and just is a nice add-on to sclerotherapy, because very frequently we can get by with doing one treatment instead of multiple treatments on people who have a large reticular system connecting all these little spider vein complexes. Now, there have been lots of lasers that have been promoted for spider vein treatment, lots of different wavelengths. 532 nanometer can be used on spider veins on the surface. Dermatologists used to love the pulse dye laser to treat vascular lesions, and that's a 585 to 595 nanometer laser, wavelength laser. We use a 940 nanometer diode laser, and a 1064 YAG can also be used. And why can these different wavelengths be used? It's because of the oxyhemoglobin dissociation curve and the absorption curve. The absorption coefficient of blood is higher than melanin, and for the KTP 532 and for the pulse dye lasers. When you get to the ruby and all those, you're going to be absorbed by melanin before you ever hit the blood, and so it's not great. But when you get toward the 940 diode, which is what we use, it's about an equal thing. So the oxyhemoglobin coefficient really does let that laser be absorbed. That's the chromophore is oxyhemoglobin in a lighter skinned patient. We do not use the laser on skin types 5 and 6, and we're very careful if we're using it on a 4 at all, but it's great for 1, 2s, and 3s. And then you see the 1064 also in the infrared range. And the only thing you have to be aware of is, yes, infrared, the 1064 can be used in basically every skin color, but its absorption by the red vein is certainly still going to be less than the melanin. So again, in a dark skinned person, it might not be the best laser to use if you're trying to get rid of the vein. So we do a combination treatment for spider and reticular veins. We use a surface laser application to the spider veins, and then we follow that with an injection of sclerotherapy in the spider veins and reticular veins. Some people do it in the opposite way, and I'll explain why we do our sessions this way. And the main reason is because you want that spider vein to be visible in order to be the chromophore for the laser. And so we treat with the laser first. On average, it's 1 to 3 treatment sessions for us to achieve 80 to 100% clearance of spider veins without recurrence. And the treatment's followed by 5 days of compression stocking. And the reason we do that is to try to keep these veins from refilling and to support them as that blood that might be in the larger reticular veins is being diverted. So the big question is, will a laser work? And I will say, yes, it can work. And I'll show you here and show you. Oops, sorry, let me go back. Okay, it started every time I've done this before. And now instead I'm just. I don't know what the error is. But anyway, that's a good video, and it shows the spider veins disappearing as you use a laser. However, there's a little trick to it, and that is that spider veins are going into spasm, and so they look like they're disappearing, but they're not disappearing permanently. It's a great marketing tool. It's great to show it on TV when I'm talking about spider vein treatment, but we know that those spider veins are not gone for good. But we're injuring them when we're doing it. We're causing them to go into spasm. And then when you follow that with an injection of sclerotherapy, you're kind of injuring the outer part of the wall as well as the inner part of the wall. And we think it leads to a little bit quicker treatment result. So this is just some examples that I have of some spider vein treatment you can do with good results. You know, these spider veins have gotten much lighter as you look at this. These are some others. So yes, spider veins can be taken care of in a medical spa, and you can get some nice results, but you have to be honest with the patient that you're not going to see something right away. It's going to take more than 1 treatment. If you're doing lasers alone, you have to anticipate 6 to 8 treatments, and then you have to decide, is that worth it? But here's some really nice results for doing some of these spider veins. And so I just want to summarize, then we can talk about some of the different lasers and how I do use lasers on veins in the office. There are multiple choices for a laser. A laser alone, I believe, has limited application. The best practice is to do a combined approach, and you have to know when to refer to a vein specialist. And that really is the most important thing. You don't want to get yourself into a situation, and you can make the vessels look worse cosmetically than better if you are treating when they are led to by an incompetent larger vein. It can make spider veins worse. It can lead to what we call matting of the skin, where you have a big pink flush under the skin. And so if you're not doing things properly, you can actually cause more harm than good. So thank you. If you have questions, you can contact me at any time, but also I'm able to take questions tonight, and I will be glad to tell you how we use other lasers. We use our YAG in the office. We just don't use it very much on leg veins. So I don't know if there are any questions at this point, Don.
Let's see.
You know, I will say that we use our long pulse YAG 1064 more for facial veins and venous lakes than for leg veins. On the leg, it's a painful procedure that, again, is going to take a few treatments, and we can accomplish the same kind of thing to treat a larger reticular vein with sclerotherapy. But on the face, facial veins under the eyes or on the lips, we can treat with the YAG laser. We have an Alma laser, so we have the Harmony XL, and we use like a 6 millimeter spot size on skin types 1 to 3, and we use a 45-second pulse width with a fluence. Probably we start at about 100 and work our way up to 150 if they need it. If we're doing a smaller vessel, a 2 millimeter spot size, there are presets already for that, and that includes our pulse width of only 10 milliseconds. And we start pretty low. We start at about 80, and especially for venous lakes, we start at an energy level of only about 80 joules. And 1 or 2 zaps is frequently all it takes, and it can be a one-time treatment. We've never seen any problems with hypopigmentation afterwards when we've done these procedures, but you've got to be careful. You just have to know not to treat the darker skin types. Again, not because the YAG laser won't work on the vessel, but with the darker skin, it's going to be absorbed by the melanin. You can indeed cause burning or scarring of the skin, hypopigmentation.
There's a few things that I wanted to share and get your comments on this, if you would. One thing that I've always, when talking about lasers, I deal with a lot of physicians and offices that have the combination wavelength lasers for hair removal.
Yes.
755 Alexandrite, and they've got the 1064 YAG, and most of them have the hand pieces that they can dial down that YAG to a 3 millimeter spot or 4 or 5, right, whatever. So they want to know, well, I got this laser, how can I use it for veins? So, and I always tell them, if you think about the vascular system as a tree down there, that for the trunk and the roots, you're going to have to do sclero or something. And then for the smaller branches and the leaves, you may be able to clean those up pretty well with your laser. And that's the way a lot of doctors I've seen use it as a cleanup tool. And
it's great for cherry hemangiomas.
Yeah.
As I said, we use it on facial veins, of course, very carefully around the eyes. The YAG can cause retinal damage to both the treating clinician as well as the patient. So it always has to be aimed away, and the patient has to have eye shields on. But we treat the lip as well. If there are large lip veins, occasionally people have those. We do use the 1064 on that, and breast veins as well. If people don't like how they look, and it might take a couple of treatments, but they shrink down with one treatment. Yeah. And then it may not be as noticeable, or they maybe will come back in 6 weeks and have another treatment.
And that's something I think a lot of people don't appreciate, is that the pressure from here up is much less than from your hips down.
Exactly.
A lot of these facial vessels, the YAG is awesome. You can make things just disappear and go away. But yeah, you have to be very careful with eye protection and all that, because YAGs penetrate, right to your back of your eyeball if you took a direct shot. I wanted to tell just a quick story that I thought was kind of humorous, and it was like, why have a laser? There was a doctor when I was working for a manufacturer that sold YAG lasers. There was a doctor I used to call on that was a big sclerotherapist. He did it all day long. That's all he wanted to do, therapy. And we thought he would want to buy a laser. And he was like, no, I'm not going to buy a laser. I'm not going to buy a laser. And finally he calls me up and said, okay, I'm ready to buy the laser. And I'm like, okay, what changed? He said, because the phone rings and people go, do you do laser leg vein treatments? No, but I click. Do you do no, click, no. And he goes, I heard this so many times. It's like, I got to get a stinking laser because, people are asking for it. So it's a good marketing.
That's exactly what I said earlier. Yeah, it is a great marketing tool.
You just have to know what you can and can't do.
Right, and what you can promise and not do. You can't accomplish everything with the laser. You really do need to do some sclerotherapy as well.
Exactly. One thing that I've noticed for people when they do use the lasers for the leg veins, they can be very painful because you're heating a lot up very quickly. So what I've noticed, and I'm kind of wondering about your approach on this, is what we would always do is, because especially a YAG, it penetrates so deep that you typically don't want to be straight down on it. You want to be at an angle. So we would typically do maybe 3 shots. So we go zap, move it, zap, move it, zap, move it.
And then the other side. And that's how I've done leg veins, is
Okay.
come in at an angle and do a few in a row, and then the other angle, few in a row. So at about a 60-degree angle into the vein.
Right.
On the face, doesn't seem to be necessary. Usually you can hit it straight on for most of the time. It works very well, but in the leg, it is a little deeper when you're trying to hit a blue reticular vein, the little larger vein,
Yeah.
millimeter and a half or 2 millimeters.
And what it seems like a lot of times that they look for to know that they've got a result is you may get this wheel and flare response.
Right.
Looks broken, or the vessel looks angry or whatever, and you know you've injured it.
That's right. And a little
get rid of it, but you started the process.
Right. And that's all with the reticular veins, those little bit larger blue veins. And with the little spider veins, you get what looks like cat scratches. And they may take, they may have that little wheel and flare that lasts several hours. Sometimes it gets a little itchy, but not usually. Usually once the laser's over, there's no discomfort at all. It's just during the application that there might be a little bit of discomfort. We use a cooler when we're using our laser for spider veins. And it seems to help quite a bit. And we also do it in little bursts. So we might do 7 or 8 pulses and then stop, and then we can do a few more. Okay.
Yeah, this has been very helpful and very educational. And this is something that I think a lot of practitioners, especially that have med spas, need to see this and understand basically what you can and can't do. So you can use a laser, you just have to know where and when to use it. And I've told people when they're starting out with these lasers, that sometimes that's all they have. They don't do sclerotherapy. And I tell them, if you're really going to get into this, you've got to do sclerotherapy. You got to learn how to do it.
Right.
And there and take care of, you can make these little vessels disappear after a few treatments, but you got to tell people they're going to come back because you haven't taken care of the source that's causing this. So it's just so important for people to know, the combination approach on these.
Right. And it's interesting because spider veins, they look pretty intricate on the surface too. It is like a bush or a tree or a spider. They arborize and they have little branches all over that show up. But underneath, there's also a totally communicating network of larger vessels that can be feeding that complex. And so you might get rid of one initially, and that's why it takes 2 or 3 sessions, because even with sclerotherapy and using a laser on the surface or injecting the surface veins as well, you don't get all the feeding vessels. So you have to let them come back, see what's left, and then maybe you're treating it a different direction that the vein may be coming from.
Yeah, and then the other thing that I see confusion about for people that don't have a lot of experience with this is the use of compression stock afterwards. They don't know how long to wear them.
Right. And it's very controversial, and it is absolutely across the board of how long people wear stocking. So I remember when I started doing this, 20 years ago, there were physicians who were having their patients wear their compression hose for 3 weeks without taking them off. First of all, a patient has to be compliant, and so you want to make sure you have comfortable compression hose. And it should be full length if you're doing a lot of these treatments, meaning thigh highs, not pantyhose, because they can't wear that overnight and it's just hot and hard to get on. But there are some really good brands of stockings. I don't want to, give a plug for anybody, but there's only one that we use because it's just so much more comfortable than any of the others. We know when we're doing our laser or endovenous laser procedures to ablate a larger vein, we have them actually wear their thigh high stockings in bed for 2 nights. And so we have open toe stockings, so they're more comfortable and their toes feel free when they're wearing the hose. But remember to start with a lower grade compression. For spider veins, probably you can get by even with 12 to 18 millimeter of compression, but we usually use a 20 to 30 millimeter of compression. You do not have to go higher than that because it's just going to make it hotter, more uncomfortable for the patient, and lead to less compliance in having them wear them. And again, it's controversial. People are still doing studies all the time to determine if compression hose is necessary at all after any venous treatment.
Okay. All right, well, I think that's probably a pretty good review of everything. If anybody has any questions, reach out to me, send me an email, give me a call, whatever. Happy to get you a copy of this video and get you in contact with Dr. Manjoney if you need to. So anyway, thanks for your time and being a part of this tonight. Dr. Manjoney, thank you for your expertise and sharing that with us.
Sure. Thanks, Don.
Okay, thanks.
Good night.